when folks who've been treated with these androgen receptor inhibitors for non-metastatic CRPC progress, the decisions about the next line of therapy are quite challenging. Remember that most of these folks are treated until they progress. So when they're progressing, they are progressing on treatment. If they happen to have taken a break from treatment and tolerated that treatment well and benefited from it and are now progressing off treatment, I have no trouble resuming the therapy and trying again. But if they're progressing on one of these agents, then we're in a very different situation. They're clearly then resistant to an androgen receptor inhibitor. I don't know of any data to suggest that switching to another androgen receptor inhibitor makes sense. We know that abiraterone, which targets ligand production, occasionally produces responses, but the response rate is disappointingly low and responses are not durable. So for most patients, what we discuss next is docetaxel chemotherapy after an androgen receptor inhibitor. Now, we are learning now that for patients who have certain DNA repair defects, PARP inhibitors may play a role, and so we're beginning to think about deploying PARP inhibitors in the right patients in this setting. We're eagerly awaiting the results of trials of PSMA-targeted therapeutics, particularly lutetium-177, PSMA-617, which is in a phase 3 trial. So I think the portfolio of options is going to broaden. But right now, folks who are metastatic castration-resistant and progressing on drugs like enzalutamide, apalutamide, and darolutamide are probably best treated with chemotherapy next.